with bones, and this is still in chapter 6, I believe, which talks about bone development, bone growth, but also what happens when we break a bone. And so we're going to talk about fractures. So it's really important, I mentioned previously, that the fractures occur in bones. They don't occur in joints. Joints can be dislocated. So when we say that there's a hip fracture, it actually means that it is or a shoulder fracture, right? It actually means that it's the bones that break. And so we can classify fractures on whether they are displaced or non-displaced. So what that means is whether the bone pieces have come apart. So we can look at their classification system for fractures. So we have displaced versus non-displaced. Okay. So that would be like, for example, if the bone moves over. And so one of the common bones that we tend to break when we fall, specifically if we have our arms out stretched, is our clavicle. And so one of the problems with the clavicle is that it has some really strong neck muscles that are attached to it. So when we break that bone, the muscles tend to pull the bone apart and it becomes displaced, right? So we actually have to put the bone pieces together and pin them in order to keep them in place so that proper healing can occur. So another way that we can classify them is simple versus compound. And what does that refer to? Does anybody know what the difference between a simple versus compound means?
Compound is open fracture.
Open, right? So that means that the bone has been exposed to the environment. So we can say that the simple is the closed, right? Compound is open. So if you see a piece of bone sticking out, then that would obviously be a compound fracture. And obviously that is really dangerous because microorganisms can get into the bone and can cause infections in the bone. So simple obviously would be, and non-displaced would be better, right? So, but a simple fracture is better than a compound fracture in terms of healing. And then we have complete versus incomplete. So complete would be where it has fractured the entire bone, and incomplete might be that where just a part of the bone has fractured. And so we'll look at it in a minute, but when we look at children's bones tend to be a little bit more malleable. And so they tend to have what they sometimes call green stick fractures, where the bone just cracks a little bit, and that would be an example of an incomplete fracture. Okay. So in your book, they have some pictures of different types of fractures. So one that can occur if your bones are very brittle, these first two actually, comminuted and compression. These are where the bones fracture in multiple places. And so these would be actually very common in older people whose bones have become brittle. This compression one is really interesting because we're going to talk about the spine in a minute. But sometimes people can get compression fractures in their vertebrae and not even realize it. And then it can lead to problems in the spine, specifically like when you see old people that are kind of bent over like this and have that bulge in the back of their neck. That can be due to compression fractures in the vertebrae, causing that abnormality that we see in the spine. Okay, so those are common in older people because of the brittleness, right? And then I mentioned the green stick. So this would be where the bone breaks incompletely. And so there's just a little fracture there. Sometimes in children, you get what are called wrinkle fractures. And so the bones are so malleable that instead of actually cracking, they actually create a little wrinkle on the bone. And those types of fractures in young children, generally they don't even put a cast on them. They might put a little splint on the child, but they don't put a cast on them. And then you can also see, this would be depression, so this would be like a skull fracture where the skull, a blow to the skull has caused fracturing of the bone. Okay, and then we can see this would be an example of a complete fracture. That's a spiral fracture due to twisting motion. And then I mentioned before that epiphyseal fractures can be bad because you can damage the cartilage, and then it is hard for the bones to regrow or continue to grow normally. So that would be an epiphyseal. So that's the plate where we have separation of the bones at the hyaline cartilage where the bones are the weakest. Okay. So if we look at the bone repair, so the mechanism of bone repair. So when you get a fracture in your bone, the first thing that has to happen is you get what is called the hematoma formation. So what is a hematoma? It is a blood, what? Blood clot. So the blood clots, and it also, there's lots of white blood cells that leave the circulatory system and actually go out into the tissues and form and actually try to clean up any debris or maybe even any microorganisms that have gotten into the wound if it's a compound wound. So the hematoma forms. And if you look at the diagram in your book, okay, so this shows that we get swelling. So we get the blood vessels that are in the bone rupture, and then we get kind of a swelling around it. The second thing that has to happen is that you get fibrocartilage callus. So this is going to then ultimately actually become a bony callus. So you can write down the second thing is that we get a fibrocartilage callus forming. And you'll notice here that we get the formation of spongy bone before compact bone. And so the spongy bone starts to be deposited, and then you get a bony callus formation. And you can actually see these in x-rays, so I'll show you a picture of that in a second. So this is spongy bone first, and then it is converted to compact bone. And then after the bone heals, then we need to remodel. And so remember that one of the functions of remodeling is to keep the bone the proper dimensions. And so this would be like osteoclasts in the bone remodeling. Osteoclasts would actually move in there and destroy the excess bony matrix that has been laid down. So the callus is actually removed, right? So it's kind of like a splint, kind of a natural splint that forms around the fracture site. And so the last thing is that we have bone remodeling, and specifically osteoclasts function to remove the callus, the bony callus that has formed.
So does the callus ever go away?
Yes,
It does.
yes, yeah. Maybe not entirely, but if you're young, I would think it would just, you know, maybe in older people, you might have that staying. Have you experienced something differently?
Well, I broke my ankle a couple years ago, and my right ankle since then has always been bigger.
A little bit bigger. Oh, that's interesting. Well, your skeleton is going to be remodeled, so maybe that will eventually go away. Yep. Okay. So this is an example of a fracture repair, and you can see even in the x-ray, you can see that bony callus that is forming around. Does anybody know what part of the body is this? What does it look like? Close. Yes. And so this is your wrist bones. So these would be your carpal bones, right? And so this is the radius, the bigger one, and then that would be the ulna over there, right? And so this is a really common fracture that they get. It's called Colette's fracture, I think, where when you stick your hands out like that and you land like that, right? You can fracture that radius, which is next to your thumb bone right here. So that's the radius.
Would you be, if you just fell off the skin, like would you be able to feel a difference?
Yes. Right, so you'd be able to feel that calyx, or the callus that's formed. Okay, so that's the process of fracture repair. So now we're going to talk a little bit and kind of review parts of the skeleton. So I have a handout here with little empty diagrams again, so you can review. So we're going to talk about the axial skeleton, and remember that the axial skeleton consists of the skull, but also of the vertebrae, and also the thoracic cage, and the sacrum. So in your book, or in that skeleton that I handed you last week, the axial skeleton is colored differently than the appendicular skeleton. Did everybody get one? Okay. Okay, so with the axial skeleton, this is the skull, the vertebrae, the thoracic cage, and remember the thoracic cage consists of ribs and the sternum, which has multiple parts you learned in lab last week. Right? And it also consists of the sacrum. And then we have the tailbone, which is the coccyx, right? So these are the tail, this would be the tail bone. So when we look at the skull, we can look at what are called the cranial bones. And there are 8 of those. Some of them are paired and some of them are singular. So can anybody start giving me examples of cranial bones and see if we can come up with all 8? Frontal. So there's only one frontal, right? Parietal. So there's 2. Temporal. There's 2. Occipital. Occipital 1. Okay, so those are, the mandible actually is facial. So the cranial bones, there's only 8. There's actually 14 different facial ones. Nope. The sacrum is down here, down in your pelvis. But the sphenoid is 1. So there's actually only 1 sphenoid. I should put this. So we have 4, 5, 6, 7, and 1 more. Okay. So those are the 8 cranial bones. They are different from the facial bones, which we'll talk about in a minute. Okay. So if you look at on your diagram, you can either label them or I'll just point them out to you if you want to keep it. Oops. Oh, come on. Next page. No, it's not gonna. Okay, well, I'll show you. Okay, frontal bone right here. Right. Parietal bones, occipital bone is in the back. The temporal bone, a lot of you didn't correctly identify the temporal bone and the components of the temporal bone. So if we look at the temporal bone, it is located right here, right, on the side of the head. what is this process referred to? Does anybody remember? You don't actually have this in your diagram, but this is the zygomatic process of the temporal bone. It is actually going to make up part of the zygomatic arch. We also have this part, which is the styloid process, right? There's going to be bones or muscles that attach there. And then this is the ear. So your external acoustic meatus, this opening to the ear. So the ear is actually in the temporal bone. And then this right here is what is referred to as your mastoid process. So this went way further than I actually wanted it to. Okay.
And the sphenoid and the ethmoid.
Sphenoid and the ethmoid. So the sphenoid and the ethmoid are part of the cranial bones. So if we look at where they are located here, so pink, this right here would be sphenoid. So you can just barely see it right here, okay? But you can see it really clearly on the inside. So you could label this as your sphenoid. This would be as your sphenoid as well. The sphenoid, there's actually a place where the pituitary gland sits. They kind of actually make up the inside of the skull, okay? So the pituitary gland sits there in the sella turcica, right? And then also it makes up part of the inner orbit of the eye. And then if we look at this bone, this would be ethmoid. Okay, so the ethmoid actually makes up part of your nasal septum, comes down, right, the nasal part, and then it actually comes up, and it actually comes up, and you can kind of see it on the inside of the skull as the crista galli. So the crista galli is actually part of the ethmoid bone. Okay, so let's look at the facial bones. So somebody mentioned, for example, the maxilla is considered a facial bone. And so that is the upper jaw, right? It also has a palatine process on it that makes up part of your hard palate. We also have the we'll do mandible first. Mandible, right? So that is your lower jaw. There is a foramen here that you need to be able to identify, right? And that is called the mental foramen. And I always just kind of remember that because I could, see the guy that's being mental, right? He's putting his hand on his chin like this, right? The thinker, right? Mental foramen. Okay. So the nasal, okay? So the nasal bone would be right here. Most of your nose is made up of cartilage, right? Hyaline cartilage. You have the nasal cartilages. But you can feel where the cartilage turns to bone, right? So when you break your nose, right, it's that nasal bone that you're breaking, okay? Now, we have a bone here that is on the inside of the orbit. And what is that bone called? Does anybody know? It has to do with tears, because that's where we cry. But that's just the location of it. And they're really, really super dainty bones, and you can kind of feel them like there would be right where that little opening to the, I can't remember what that's called. Okay, those are called lacrimal. Lacrimal. So we have two nasal, one maxilla, one mandible, right? This would be lacrimal. So we have actually two lacrimal, one on each side.
What was the process in the maxilla again?
It was called the palatine process in the maxilla.
What are those dots on the frontal lobe?
Those are also openings to nerves that come out. Yeah, probably to squint your eyes. Okay, so this has a name. What is that bone called? Zygomatic. So it also makes up the zygomatic arch, but it's not the entire bone, because remember that the zygomatic process on the temporal bone also makes up that zygomatic arch.
There are two of those.
Yes, there are two of those. Okay. Now we have a bone here that comes up, and what is that called? This has got a V. The vomer bone.
The foramen above the eye.
Yes, you don't need to know the foramen above the eye.
Is that that little pocket above the eye?
Right here. We have our lacrimal glands are there. You know, I'm not sure. I'm sure it's a nerves that come out. What? Oh, to move your eyebrows? Yeah, it could be that nerve that kind of innervates that part of the skin. Okay. So I wanted to point out that if you look at these bones broken down, remember that there are sutures, right, that connect the bones together. And then if you look at the inside of the skull, right, this is not part of your handout, but if you look at the inside of the skull, you can see, for example, the different bones. And so this would be an example of the sphenoid bone. So the sphenoid bone makes up the interior part of the skull. Sometimes it's said to be a butterfly-shaped bone, right? There's only one of them. And this spot right here is what is called the Turk's saddle, or sella turcica. You don't have this one. But I just wanted to point out that that is where your pituitary gland sits, and that's a really important part, okay? And then this just shows it from the side, right? So this would be showing it looking down on it, so that would be inferior. This is kind of looking at it from a anterior position. And then if we look at the diagram of the ethmoid, so remember that the ethmoid gland makes up part of the nasal conchae, right, which actually make up the inside of the nasal cavity. And so notice that we have all these tiny little bones, right? And so we're going to talk about these in a minute, because these make up the ethmoid sinuses. This one comes down and connects with the vomer, so that perpendicular plate. And then this actually comes up and connects to the dura mater on the brain. And so that is what is called the crista galli. And that is also, that means, what does that mean? Crista galli is actually on the ethmoid bone. I think that means something, I can't remember what that means. Okay. So let's look at the sinuses. Okay. So part of the skull, we have these sinuses, and one of the things that they do, so if we look at the sinuses, is that they help to moisten or humidify the air. So we actually lose a lot of water, via respiration. So when you think about if you're in a room with a wood stove and it's really dry heat, right? You get thirsty really quickly because you're losing a lot of water across the surface of your respiratory system. So as you breathe out, you're breathing out water vapor. And the reason for this is that our lungs have to be moist in order for gas exchange to take place. So in order for oxygen and CO2 to diffuse across the surface, we have to keep our lungs moist. So this is one of the functions of the sinuses. And we've kind of looked at these in lab. If we look at them from an anterior perspective, this is called what? What bone is that near? What bone makes up your upper jaw? maxilla, right? And so this is called the maxillary sinus. Right? What bone is this found in? This purple one. It's not purple on your diagram, but yes. So this is the frontal sinus. Right? And then I mentioned that there is lots of little bones in the ethmoid, right? Lots of little tiny bones, and they make up little air pockets. And so this would be the ethmoid sinus.
Is it all one?
All one.
Are there two different sides of there?
Okay, no, that's a different one. So the one that is yellow is called the sphenoid. It's because it is in the sphenoid bone, right? So they're associated with they're called what bones they come from.
So I had major sinus surgery when I was about 15, and they took all of my sinuses out, realigned them, and put them back in. Would that been all of those?
I had sinus surgery too, but it was only ethmoid, and they just took them out.
Yes.
So they just went in and they just removed the little bones in the ethmoid sinuses and created one big space. I think it would primarily be ethmoid, but I haven't heard about them putting them back. Are you sure they put them back after they took it?
They said they had to clear the growth. I had tiny little cysts throughout them, so they had to clear those out. And I had to have my sinuses stuffed with cotton for like the entire summer. They broke my nose because one of my mouths is twice the size of me.
Yeah.
But it was a huge surgery.
So since I had some sinus surgery, right, but it actually has kind of affected, it's changed my life, but because I was constantly clogged up. But I actually also think that it's kind of affected when I breathe. It feels like the air doesn't get as moistened as well. So actually, I think they took my ethmoid. I know he took all the little ethmoid bones out and just created one big chamber. So there's a lot less surface area.
How do they go in? Do they go in through your nose and take those off?
Yeah. So they just, because the ethmoid bone, right, is just, if you remember where it's located, it would be just like right up in here. And so they just go in through the nose. Yeah.
And then how they would get all the like easy sinus through the nose?
You know, the maxillary sinus is in it's in this bone. And so I don't think you can reach it from, I mean, obviously it is connected, but it's different. So when you have like a sinus headache and it's up here, right, those are the frontal, and then if you have it and it's in your cheekbones, those would be the maxillary sinuses. So let's just label this. So this is maxillary. You could do your extra credit on that. That would be interesting. So this is frontal. This is ethmoid. And then this one would be sphenoid. So this one I just wanted to put on here because this is a cross section. The only two structures that you can, or actually the only two sinuses that you can see here are the frontal. And so notice how there's two components to the frontal. So these would both be frontal. And then I wanted to show you how large the sphenoid one was. So this would also be the sphenoid.
So the sphenoid comes all the way down to your jaw, pretty much?
Yes.
Is the sphenoid or maxillary?
I think the maxillary is bigger, just from this picture. It looks to me like my maxillary would be bigger than the sphenoid that would be located up here. So the other function of these are resonating chambers for your voice, right? So when you talk about, you know, being able to project your voice, I think I mentioned this in lab, they're resonating chambers for voice. So we'll put other function besides just moistening the air is their resonating chambers. kind of making the sound waves bigger by their vibrations. Okay. The next part of the axial skeleton is the vertebral column. And I didn't give you this diagram, but I wanted to point out that in this diagram, you can see the normal curvatures of the spine. So this region is called the cervical region. So the cervical is the neck. Oops, cervical. Right? How many cervical vertebrae do we have? 7. Okay. And if we look at it from the back, we would say that its normal curvature is that it is concave, right? So if I'm looking at it from this direction, so you might want to draw, so it looks like this. I'm looking at it from this direction, right? And that is concave. So the way that I remember the difference between concave and convex is the concave makes an indentation, right? Convex goes the other way. So these are the curvatures of the spine. So the normal curvatures. And these actually is kind of interesting. The cervical is concave, right? So the cervical would be the concave one because we're looking at it. It's kind of interesting when we're born, all of our curvatures are convex. So we're kind of born, if you think about fetal position, turning yourself into a fetal position kind of makes all those, in a baby, if you look at them, they're actually almost all of their curvatures are convex instead of concave. And then as we develop, as we kind of start to sit up and stand up, then the normal curvatures of the spine form. Okay? So then we have the thoracic, right? And there's how many of those? 12, right? Not 2, 12. And these connect to the vertebrae. The other ones do not. Right? So the cervical and the lumbar vertebrae and the sacrum do not connect to the vertebrae. The vertebrae only connect with the thoracic. So this is convex. So it looks like this. Right? So if we look at this, this would be convex. Looking at it, it kind of sticks out. So the lumbar vertebrae would obviously be concave. There's 5 of those, right? They are concave. And then when we look at the sacrum, remember that the sacrum is composed of fused vertebrae. So during embryonic development, these vertebrae fuse, right? And so you can still see that there are holes through which the spinal nerves exit. But the spinal cord actually stops. When we talk about the spinal cord, it actually starts up or stops near L1. So the spinal cord ends here, and then the nerves just come down. So we'll talk about that when we get to the nervous system. But these are for the spinal nerves coming out and innervating the lower leg, for example. So the sacrum and the coccyx, which are the tailbones, and these differ. So some people can have more bones than others. I think the average is 3, right? But some people have even more. I think they might show 3. 1, 2, 3. Some people can have, I think, up to 5 bones, and their tail might be a little bit larger. You know, and some babies are born with their tail sticking the other way, right? And they look like they have a tail, and they actually have to have that surgically removed, right? Huh? Can you have less than 3? Maybe 2. I think maybe 2 to 5, I think is the rule.
What would dictate? What is it like? How tall you are? Just your bone structure?
I don't think so. When they did my x-ray, they told me that I had a really interesting bone. I actually have an extra bone that looks like this, and it's called a sesamoid bone, and it's similar to the patella in that it's a bone that is formed in the tendon that connects down here. So I have this, I don't know why I have an extra little bone down there. Just wanted to tell me that. Okay, so this is, this would be, so it's going this way, right? So that is convex. So those are the normal spinal curvatures in an adult. Now, sometimes these curvatures do not form properly. And so I'm sure everybody knows about scoliosis, where we have the spine having an unusual lateral curvature. So this is what is referred to, this would be problems with curvature. So this is scoliosis. Scoliosis. That's how I spell it. Is it scoliosis? Sorry, let me look it up. Okay. Is that how you spell scoliosis? I think it's is. Scoliosis. Sorry. Scoliosis. I think it's with a, I think it's that instead of that, sorry. Okay, so we have a weird lateral curvature, okay? Things that this is really extreme, right? Sometimes people just have a little bit of a one. And if in this particular instance, it doesn't have anything to do with like unusual patterns of like wearing weight, like, you know, like some people, and your doctor will tell you this, your chiropractor will tell you this, that wearing a heavy backpack on the same shoulder day in and day out is not good for your spine, right? Because you start to build up muscles on one side and not on the others, and it can cause just a minor curvature of the spine. But something like this is more of a problem developmentally. So this probably happened developmentally as she was in the womb, okay? So that's scoliosis. This is the abnormal curvature, right, of the thoracic, and kind of, sometimes it can be up near the neck too. So we have extensive curvature of the thoracic, and this is called kyphosis, right? So kyphosis is a more dramatic curvature of the thoracic region. So sometimes this is called the dowager's hump, right? And I mentioned before that sometimes this can be due to compression of the vertebrae, and actually where the vertebrae have fractures in them that have kind of caused this hunching forward. Now, sometimes people get like this from doing too much of this, right? So if our arms are always here and like we're always texting, or if we're always hunched over the computer, right? You're gonna start to get like this, right? And in the most dramatic ones, you see people walking around like this and they can't even stand up straight, right? So with physical therapy, a lot of the times you can get people to roll their shoulders back and to stand up straight and get that normal curvature in the back. So if you find yourself like this, you want to make sure that you stretch and open up the chest muscles so that you don't end up developing that hunched spine.
How long will that take to get that person back to the spine?
You know, I'm not sure. Although I've seen it on YouTube. I've seen it on YouTube where they actually took a woman that was hunched over like this and actually got her to come back straight up. So I think it's possible. I think it would just take a lot of.
And scoliosis, can you get them back to
you can put braces on them when they're young, when their spine is still developing. But I think some of this is just, they do have surgery for it. They help. Yeah. Oh, okay. Okay. I think that you can do a little bit with physical therapy on that one too. Okay, so what do you think this one is? This is an accentuated lumbar curvature, right? So this would be an accentuated lordosis. So this is accentuated thoracic curvature. This is a lateral curvature. And lordosis, right, is an accentuated lumbar curvature. So that's in the back of the body. So it's common in children, right, because sometimes they have like the big belly, right? It's also common in pregnant ladies. So pregnant women tend to stick out in order to hold their body weight and stay balanced. They will stick out their belly, right? Or their belly sticks out, and then they lean back to help support it, to counterbalance it, and that creates lordosis. So this can sometimes cause problems with lower back, and specifically, it can cause problems with disc herniations. So it's important to try to get people out of that lordotic posture and more into the upright, kind of tucking your butt kind of posture. Okay, so that's lordosis. Okay, any questions about that? Okay. Okay, so if we look at the vertebrae, it's important to realize that the vertebrae articulate with each other. And so if we look at the structure of the vertebrae sit one on top of each other. So they have these articulations which are called facets. So so we would say that the vertebrae articulate with one another. No. Okay. So facet joints specifically are joints where the pieces of the bone are flat. So this is two flat bones coming together. And oftentimes, this is what your chiropractor, if you go to a chiropractor, this is what they're trying to sometimes realign, is those facet joints. And when the popping sound has to do with the air that is in the joint, when they move the joint and it pops, that is just the kind of the movement of the air in that joint. And so you can see here that we have a facet here that would be inferior, right? So this vertebrae right here, this lumbar vertebrae, I can tell it's lumbar because it has this big spine that's sticking almost straight out. This lumbar vertebrae here has a facet joint, and so this is the inferior articular vertebrae facet, and this would be the superior articular facet, and those come together, and those sometimes become arthritic. And so sometimes you get damage of the cartilage here, and sometimes you get bony spurs forming. And so they, you know, when you're older, and like when they take x-rays of my back, they're always saying, well, you have facet syndrome. You have, you know, your facets are just starting to wear out, and they're starting to get little bony spurs. And that just causes arthritis in kind of normal wear and tear arthritis in the back, okay? Now also notice that the central bodies here are separated by what are called intervertebral discs. So we have what are called intervertebral discs located between the central bodies. And does anybody remember what type of cartilage is the intervertebral disc? Fibrocartilage. So this is fibrocartilage. Also, you can see that there is connective tissue sheath running in front, anterior, and also posterior here that helps to stabilize the spine. This would be a ligament because it's connecting bone to bone. Some people ask, well, I want to see a ligament. So you can see here, these are ligaments because they're connecting bone to bone rather than muscle to bone. So that actually helps to support the spinal column, these ligaments that run down the length of the vertebrae. Okay, so this would be my intervertebral disc right there. So notice one thing that is not shown here would be your spinal cord. So the spinal cord actually runs down through the vertebral foramen. So this would be showing just one lumbar vertebrae, and this is the spinal cord, right? And then in between, we have these little openings that allow the spinal nerves to exit the spinal cord. And so those are called the intervertebral foramen. Okay. So I wanted to show this part because this shows what is called a herniated disc. And this is where part of the disc ruptures and can press either on the spinal cord or on the spinal nerves. So we'll say that this is called a rupturing of the disc, and we're going to look at discs in more detail later. So the rupturing of the disc can put pressure on either the spinal cord or the spinal nerves, or both actually, but I think it is more common for it to be spinal nerve. So if you look at this ruptured disc right here, this is a diagram from your book, you can see that it's pressing on the spinal nerve, but not on the actually very much on the spinal cord. So if we look at what is referred to as an MRI, oops, we can sometimes see, let me show you a different one. Oh, where's the other ones? Sorry. Okay, so this is a diagram of an MRI. So you can see that in these particular instances, we see this is the this would be the spinal nerve. So this would be in the lumbar region of the book of the back. So this would be the sacrum, right? This would be like L5. So I think this is L5, L4, 3, 2, 1, right? So this is showing a herniation here between L5 and S1. And that is the most common herniation. So L5 to S1. And so what that means is that that is the disc that is between the last lumbar vertebrae and the first sacrum. And here you can't see, they've actually, in this particular picture of an MRI, you can't see the spinous process here, but you can see the spinal nerves that are running down the length here, right? And then this would be the herniation. So this particular herniation often leads to what is called sciatica, right? So sciatica is where you get that pain that comes down like in one side of your butt and then comes down all the way, and you can feel a burning or a tingling or a painful sensation all the way to your toes, because your sciatic nerve is actually exiting there, right? It's actually coming down through there, and that herniation can put pressure on that. Okay? So that's the most common. So one thing that they can do is they can actually go in, and I actually had to have this done. My sciatica was actually so bad that it gets so bad sometimes that you can't walk, so you can lift up your leg and you put it down and you start to drag your legs. So you see people walking around dragging your legs. So I was walking around like this, right? I'm dragging my leg. I'm in excruciating pain, right? So one thing that they can do is they can go in and they can do what is called a discectomy. So that's where they go in through the back of the body and then they just remove that herniation. And they can also do a fusion, where they actually put a titanium plate there and to support the spine, and they can actually remove the disc entirely and put cadaver bone in there instead, right? So that would be the cure, quote unquote, for that. There's lots of controversy now, however, if you go to a physical therapist for this, their argument is that we're taking too many MRIs. And the idea is that people are probably walking around with disc herniations all the time and not having any problem with them, right? But let's say that I have sciatica, so I go in and they say, oh my gosh, you have this disc herniation. Well, it might not necessarily be the disc herniation that is causing my sciatica. It might be something else. So then they go in and they do unnecessary discectomies. And so there's this controversy amongst physical therapists as to whether you should even get an MRI. But I guess if it gets really bad, then they'll give you an MRI. But generally, they don't want to give you MRIs anymore because they don't want to find them because they think it might not be the cause of the pain. Yeah.
What else could form if it wasn't a herniated disc?
What could cause it? So it could be due to muscle tension. So one of the other things that causes sciatica is that specifically there's a muscle called the piriformis, which we'll talk about next quarter, where if that gets tight, that can actually pinch the nerve, the piriformis nerve. So that's why in yoga, for example, you do those stretches that try to stretch out the piriformis, like pigeon, for example, in order to relieve some of the pressure on that.
So is that one way you can fix it?
That's not one way you can fix a herniated disc. Now, the thing about herniated discs that are really interesting is that eventually they will fix themselves because we have these white blood cells that will go in here. So we have these macrophages that will actually go in there and they'll eat that, right? But the problem is that you might be in pain for 2 to 3 years and you might stop moving and then you might have other problems, right? So the idea here is that you should never stop moving, right? You have to keep moving, you have to keep exercising. Once you start moving, then you're gonna get more problems. And then if you're willing to, wait, then that might go away by itself. That's not a very big herniation. Mine was actually much bigger than that.
Can there ever be like a herniation in 2 different discs?
Yes. So that's the other concern. So the other concern, so the lower back, and I had other pictures I wanted to show you, but the lower back, there is no spinal cord here. So the spinal cord ends up here. And so these are just spinal nerves. And so compression of the spinal nerves is not as bad as compression of the spinal nerve cord itself. So I've had surgery, fusion in my neck. So when you have a disc herniation in your neck region, you risk paralysis because that herniation can actually damage the spinal cord, and it's up so high that it could cause damage to even the nerve that goes to your diaphragm. So my disc herniation in my neck was so bad, they're like, well, we have to get you in within the next week because if you were in a car accident or something, that herniation could actually paralyze you. And so I've known people that were fell over, and became paralyzed because they fell off off of a chair and fell backwards. And it might have been that they already had a herniation, and then they're fully paralyzed because of the damage. And so one of the problems, however, with getting fusion in the neck is that it makes it more likely that you will have herniation above and below the fusion. So that's why you want to be really, it has to be really serious in order to get a fusion. So if I get a fusion here, right, then that actually might make it more likely that I will get a fusion or that I'll get a herniation. You can have herniations up and down your spine. And the point that the physical therapists make is that you can have herniations up and down your spine and have no symptoms, right? So the question is, do the symptoms actually come from the herniations themselves? Okay, so those are the intervertebral discs, and we'll talk a little bit more about what they are made of when we talk about the joints. Okay, so the last thing I want to talk about are the 2 cervical vertebrae that are really important that allow rotational movement of the head. So C1, there was some confusion of this in your lab. C1 is atlas. It is the vertebrae that articulates with the occipital condyles of the occipital bulb, okay? So we would say that the superior facets articulate with the occipital condyles of the occipital bone. And the occipital condyles are near the foramen magnum, right? So that is where the spinal cord comes up, or you could think of it going down, right? Goes from the brain, connects to the brain, okay? So this is the atlas. So when we look at it, we see that it has these large facets, right? That would articulate with the occipital. Then it also articulates below. So these are the inferior ones that articulate with C2. Okay. The atlas has no central body. When we look at C2, this is the axis. And it is believed that it has actually taken over the central body of the atlas. And so that is this structure right here. So the dens is actually embryonically would have been that central body, but notice that it's no longer on the atlas. It has been fused to the axis, right? So the central body has the dens. Dens means like a tooth-like structure, and this allows for the rotation. So the dens kind of sits in the space where the central body would have been, and it rotates, right? So this is its rotation. So it rotates, rotation of head. So you could say the dens would be the central body of the atlas. Developmentally. So these processes allow for things to attach to them. Notice that there is no spinous process on the atlas. There's one on the axis. And then also notice that there are little holes here that are called transverse foramen. And a lot of the cervical vertebrae have these. So these holes, the transverse foramen, allow the major blood vessel. So the carotid artery, or the, maybe not the carotid, it's a major artery that comes up, it's either internal or external carotid, that come up and into the brain, right? So the transverse foramen in cervical vertebrae, so I'll put cervical vertebrae have transverse foramen. Those are holes, right? This allows for blood vessels to travel through and up into the brain. Maybe it's the vertebral artery that travels that. Okay, so they also have what is called a bifid spiny process. Bifid, B-I-F-I-D, bifid. And so a bifid spiny process has like two little bumps on it like this. If I were to draw my spiny process, it might look something like this. So it has two bumps, okay? So when we're looking at cervical vertebrae, those are two characteristics of the cervical vertebrae that you do not see in the thoracic or the lumbar vertebrae. Remember, the thoracic vertebrae actually have their spinous processes point down. The lumbar vertebrae are really easy to tell because they're big, but they also have spinous processes that are big and then they project straight, pretty much straight out, maybe just a little bit down. Okay. But the cervical vertebrae have those spinous processes. Let's see if it's shown here. Okay. So those spinous processes would be like right here, right? And remember that C7 is the big one that you can feel in the back of your neck. Okay, So on Monday, we will finish up with the skeletal system, and we will start on joints. So you might want to read ahead a little bit on the chapter on joints, which is chapter 8. Yes, there'll be a quiz next Wednesday as well. Hmm?